So hi and welcome everybody. We're going to be talking about something that I'm incredibly excited to be talking about today, and that's how the American Society of Anesthesiologists, and anesthesiologists in particular, are very well positioned to really move the well-being conversation much further forward for us than we've seen in the last few years. I want to talk about why that is, where we're going, and give you three very specific examples that show that commitment, that depth of expertise and research, and the really exciting prospects for the field in the next few years. I am just introducing this panel today, so I'm going to take as little time as possible. Let's see. Oh, I'm trying. Do I have to point it at it?
No, the first one you have to.
Oh, the first one you have to. Okay. Maybe? Okay. Can I just say next slide? No, I'm just kidding. So just to set the context, the modern well-being movement happened, and it started around 2012 when the first major data set on burnout was published. And that was the one that said, half of physicians are burned out, which actually what the data said was that half of physicians were at high risk for burnout. And they really established a network of researchers and people looking at why people were burning out in medicine and what to do about it. Unfortunately, that conversation has been led by and really for internal medicine, primary care, psychiatry, and the types of stressors they face, which is predominantly frustration-based, things having to do with administrative burden and frustrations with the electronic health record. They're not really the things that are getting to us. The things that are getting to us have more to do with vicarious trauma and post-traumatic stress and the high demands of our work intensity. And so while it has been incredibly well-meaning and effective in those groups, it has not been particularly effective for our groups. The other thing is, and it's mentioned here, our morbidity is a lot different than those groups that I previously mentioned. Why is our job so hard? We have a really high stakes nature. We have a really high work intensity. We can't really tolerate error. Our work hours are really unpredictable. Raise your hand if you've ever gotten the ETA text from your spouse and you just shake your head and laugh. There's a need for constant vigilance and unpredictable events. And the load is just physical, cognitive, emotional, spiritual. It's a very high load. It also makes us very close to one another as colleagues. Unfortunately, in not just us, but other perioperative and acute setting clinicians, and those are to include anesthesiologists, surgeons, critical care doctors, emergency medicine doctors, OBGYNs, very similar kinds of vicarious trauma and post-traumatic stress and work intensity and unpredictability. Those groups, unsurprisingly, have the highest rates of suicide. They have the highest rates of substance use disorder. They have the highest intention to leave. And if you take all those groups together, they drive 80% of a hospital's revenue. The ORs really drive 70% of a hospital's revenue. And they don't really have a lot of time to study these things because they're busy taking care of patients, right? And that's probably why the conversation hasn't been driven in the right direction, in my opinion. So who should lead the charge? I think we should lead the charge. We hold the highest morbidity, so it's really our imperative and our charge to do so. It's our responsibility. We're vital to the solvency of all these healthcare systems, right? We also have a really well-developed network of well-being experts within anesthesia that's not mirrored in any of the other PAS specialties. We also now have a way to diagnose not individuals within a workplace, but the actual workplace itself, far more upstream, so that we can make changes and measure those changes and improve these terrible downstream outcomes of suicide, substance use disorder, lack of engagement, and loss in the workplace. We also understand what we go through. So today, I'm really honored to introduce three incredible researchers, certainly not the sum total of incredible researchers in the anesthesia field, but three of them. Dr. Rebecca Margolis is at UCLA. She is the Director of Wellbeing for the anesthesia department there. She's also the Vice Chair of the Committee on Physician Wellbeing. I said UCLA, I meant CHLA. My coffee is not yet complete. I see them. Listen.
Just across town.
Yeah.
Fine.
That's all right. We got psychological safety. It's okay. We can move on. But across town from Rebecca, who is at Children's Hospital LA, is Elliot Higgins, who's at UCLA. And he is the Director for Wellbeing at their Department of Anesthesia. And then Stephanie Black just moved up to Dartmouth Health, and she is the Vice Chair of Faculty Development there. It's a very exciting new role for her. So Rebecca's going to talk about peer support 2.0. What is the impact of those adverse events today in anesthesiologists, and what do we want, and what do we do after those events? There's some exciting new data that we have just analyzed. We sort of pushed our statistician to get us those results earlier than I think he had planned. So big shout out to Steve, who's not here, but he scrambled for us to get this together in time. Then Dr. Higgins is going to talk about the WISH metric, which I'm not speaking hyperbolically when I say the WISH metric is going to be absolutely game-changing for physician well-being and clinician well-being throughout all of medicine, but especially in PAS clinicians. And the well-being curriculum is what Stephanie Black's going to speak to, and it's going to talk about how we are going to provide a service to medicine broadly. So all of these things together showing how, as anesthesiologists, as the field of anesthesia, we are ready, prepared, eager, and owning that next step in addressing well-being and improving our workplaces. So without further ado, I'm going to turn it over to Dr. Margolis.
Good morning.
Y'all, she said good morning.
I know. Good morning. Guys, I've had 2 cups of coffee. I'm just warning you. Okay. Good morning. I'm going to walk around because I've had 2 cups of coffee. So, who in this room has had a memorable adverse event? So I think I see every hand except Max, but he's not an anesthesiologist. We'll excuse him. But he's important to what you're going to hear about today. So that's every one of us. So we have new data that I'm going to talk to you about that has not yet seen the light of day. You guys are going to be the first to see it on what is the effect of those hands and those memories that we have on our careers, on us, on our families, and maybe what can we think about doing about this in the future. Oh, first slide, hold on.
I got you.
It's all right. So this is what we're going to talk about. So if you've ever been to a lecture on peer support or you've given a lecture on peer support, you've seen this data because there is one previous data set on the effect of perioperative catastrophes on us. And what this study, which is from 2012, but the data was collected in 2009, showed us is that after a perioperative catastrophe, 88% of us needed time to recover. 67% said, so 2/3 of us said, in the next 4 hours, my care was compromised for the next patient. 19% of us said we never recovered from that memorable event. And 6% of us were given time off after an adverse event. So this is where we're coming from 17 years ago as a reference point. So we thought, the other thing that this study revealed is that we work in a minefield. I saw everyone's hands basically go up. This study showed that 84% of anesthesiologists have a perioperative catastrophe. So this is the first validation and very important. A lot of us use this data to get support for peer support programs, support for time off after adverse events. This was really the first data set that said, this is important and this really affects us. So this is what my waist looked like when I was a resident in 2009. I had an analog watch, a BlackBerry, and 4 pagers. So this is when the data was published. So as the kids say, it's been a minute, so we redid it. So in June 2025, the ASA sent out this survey to all of our members, and these incredible people, this was really Amy's brainchild, and she said, we have to redo this. We have to see where we are. We have to see what the ASA members need, what our colleagues need. And all of these wonderful people helped me and Amy put together a survey. And what we really wanted to do is take the survey from 2012 and reuse a lot of those questions so we could have really benchmark data to say, have we made any progress, or are some of these things static? So that's what we did. I got the data 2 weeks ago. And this is what it showed. What do we think is a perioperative catastrophe? If the patient dies in the OR, obviously. I don't know what happened to the other 4% of people who said that wasn't a perioperative catastrophe. But anyway, seems like a perioperative catastrophe to me. Serious injury is a result of an anesthesia procedure, cardiac arrest. We operate on the wrong patient. We operate on the wrong side. Patient has a stroke or brain injury, a heart attack. All of these things that you can see, vision loss also. And then interestingly, in the comments, and probably something we should have included, many people said loss of airway, which makes a lot of sense. So those are what, just as a framing, this is what we consider a perioperative catastrophe. So in our data set, 94% of people experienced a perioperative catastrophe. That's up 10%, and that's probably consistent with surgical data that says our patient population is getting sicker. It is real. All of us are going to have this. Ooh. And if you actually look at, well, how many of these events have you had in your career? A whole lot. Only 9% said they've had one. Most people have had more, and shockingly, 17% of people who answered the survey said they'd have more than 10. So this is an inevitability of our practice. So if you ask respondents to say, pick a memorable event and answer the questions based on the memorable event. About half died in the OR, 3/4 died within 24 hours. And interestingly, only 14% of people were named in a lawsuit. And this is the #1 reason that people say, I'm not going to seek peer support, but it was far less common, frankly, than I thought it was going to be for that catastrophe. So what are the nature of the cases? Very interestingly, 40%, 2/5 of them are elective. This is very powerful because randomly enforced events are the most potent. So you cannot see this coming. 60% are what you would think, urgent and emergent, right? And then about half of the pie you see is ASA 4s and 5s. The rest of them are ASA 1s to 3s. So it is not always our sickest patients. So we asked, hey, do you think that this was anesthesia related? 65% of people said no. About the same people said, was there a medical error? No, it was not preventable yet. So 2/3 of people said it's probably not preventable. 71% said they feel responsible. They feel shame. So this is maladaptive perfectionism of all of us, probably all of us sitting in this room. Of course we feel responsible, even if it's not our own fault. Okay, so what actually happens to you physically? Are you crazy because you feel terrible after these events? No. Most of us are not sleeping. More than half of us have sleep disturbances. We are fatigued. We're hypertensive. We have rapid heart rates. We have muscle tension. We're rapidly breathing. If you take everybody all together, more than 70% said they had a physical sign after they had an adverse event. What about psychosocial symptoms? It's almost all of us. I'm going to show you the list of things that it was, but every single one was greater than 30%, and altogether, almost everybody had a psychosocial symptom. These are things like self-doubt, frustration, remorse, reputation damage, very real, grief, intrusive memories, extreme sadness, and depression. They were separate. Psychosocial symptoms after an adverse event are normal. It is what every one of us is experiencing. So what about after the event? What do we do? I told you that 2/3 of people don't think that their care is compromised. So do people want to continue care? About 43% wanted to continue care. 37% did not want to continue but had to. However, 19% actually it happened at the end of the shift, so no decision was made, so it's probably about half. And then 8% were relieved. We were at 6% before. We're only at 8%. 8% did not want to continue care and were relieved. So we have a gap. But do we still feel that patients are compromised in the next 4 hours? You're probably looking at this data and say, Rebecca, this is the same data you told me 5 minutes ago. 2/3 of respondents said in 2009 that their care was compromised. The number was exactly the same 17 years later. We think our care is compromised in the next 4 hours, and we think it's probably compromised in the first 24 hours. So how much time? I said we should probably give time. How much time? Well, it's a bell curve. Some people, sorry, I'm getting excited with this. Okay. It's a bell curve. Everyone takes a different amount of time, and that's probably dependent on the event and other things, but not everyone's the same, so we need to have options. But very interestingly, one number was exactly the same as it was 17 years ago. 19% never recovered. That number is the exact replica. This is SCAR. This is SCAR that is unchanged. So the other interesting thing is we asked people, well, did you consider leaving the field? after one event. Almost a quarter said yes. This number is double what it was the previous survey. 12% said they considered leaving the field. There's like 1 million panels on workforce at this meeting, of which I'm going to be going to. Some of you are probably speaking on them. This is a workforce issue. People have one bad event and then they think about leaving the field. This is where we can intervene. Time off after an adverse event. Half want time off. If you give people time off, half of them came back within the same shift, which is interesting. I'm sure there's division chiefs sitting here who are like, you want time off? Well, how much time off? This is hard. It's hard to do logistically. Half want time off and only half are going to take it if you offer it. But if you offer it and people take it, almost everybody says it was helpful. For those that never recovered, those 19% that said I've never recovered, they have a much higher percentage of ASA1 patients. 46% were ASA1 patients, probably not surprising. About a quarter said that they had a medical care error related to it or thought it was preventable, and of those, almost 40% considered leaving the field. So, should we talk about these things? We're scared about legal ramifications. More than 80% of us are talking about these events after. Who do we talk to most commonly? The team involved, an anesthesia team not involved, the surgical professionals. I don't care if you call it peer support. We're talking to somebody. That's what peer support is. So it is normal. Only about a third of people actually talk to their families about this. So peer support programs or informal peer support is the norm after these events. What about talking to families? We're stuck in the operating room with our patients. We can't necessarily go talk to families. 98% of us think we should be involved in the conversation after a perioperative adverse event. And more than 70% of us are comfortable having that discussion. 25% of us participate in these discussions. Why? Because we're stuck with the patient, or we're trying to transport to the ICU, or we're mobilizing resources. This is another gap. We need to figure out how to get providers to be able to participate in those conversations with families. So what do we want? We asked people. We said, what do you think is the most helpful thing? Most common answer, 80% want a non-punitive clinical debriefing. They want to debrief this case. Most people want to be offered time off, remembering only half will take it. Peer support. They want some post-event follow-up, right? Oh, sorry. They want institutional support, a mentorship, legal support, some time off, and some adverse event communication training. That's how do we talk to those families about this event? I want some training on that, because most of us think we should be doing it. So what did we learn? This is going to happen to you. Psychosocial symptoms are normal. Shame is pervasive. Twice as many of us are considering leaving the field after one adverse event. 20% of us will never recover. So what can we do? And this is really where the ASA Committee on Physician Wellbeing, which many of us are part of, want to think about moving the needle. So if you have ideas about what would be helpful, that is also what we're here. This is the first blush at the data. I opened it 2 weeks ago. So we want to offer debriefings. So we need some type of tool for people to know. You're in private practice, how do we offer debriefings? How do we do this? What is best practices? Enable providers coverage so they can go talk to families. Offer time off, even if it's just for the rest of the shift. Train peer supporters and check on people, and this is important. A lot of people don't want to talk about it, and just checking on them, not at the moment, but if you are in a leadership position, checking on them a week later, a month later, there's some institutional recognition that something happened to you, because nobody usually talks about it. If you do nothing else, there is, if you don't know how to ask your colleagues how to be, what happens after somebody dies or something happens, this is a one-page document on what do you do and how to become a peer supporter, even if it's just casual training. So, thank you.
Good morning, everybody. I'm just going to put my slides here. Woo. All right, good morning. I'm here to talk to you about WISH, or the Wellbeing Influencers Survey for Healthcare. I'm going to jump in because we've got a lot to go through. A couple things up front. We do get funding from the Society for Education and Anesthesiology. We're super grateful for that. I want to emphasize up front, WISH is free to use for well-being and research purposes. This is not a commercial product. Okay, so framing thought. To make things better for health workers, we have to improve our systems. That's not a controversial statement. amongst people who spend a lot of time thinking about the science of well-being improvement or advocating for well-being improvement for anesthesiologists, for health workers. I want to take that and advance that just a little bit, and that is, if we're going to improve our systems, we need to measure what shapes well-being within them, okay? So you could be thinking to yourself, why do we need a new metric? Let's zoom out. If you're at all familiar with the science of well-being improvement for health workers, you're familiar with what I call the big three: burnout, professional fulfillment, and intention to lead. These metrics have dominated over time. We're on autopilot here.
Yeah.
These have dominated over time. They are important. I am not here to tell you that they're unimportant, but the thing is, all of them focus on the individuals. I think the slides are on their own, so I'll bring it back. It's going to be fun. But all of these things are focused.
Oh, they are.
They're focused on individual cognitive affective states. Right? Are you burned out? Are you fulfilled? Are you going to leave? And that's at odds with the consensus that it's our systems that need to be made better, not our people, which is also our framing thought. So the problem statement that's been in front of us for some time now is, how might we quantify health worker well-being through a systems lens? If we were to make a very simple model, a hypothetical model for how to do assessment and measurement of occupational well-being for health workers from the systems lens, to me it would look like this. Upstream, we've got systemic well-being influencers, things like leadership support, psychological safety, perceived social support. Midstream, we've got these cognitive affective states in individuals, things like burnout, professional fulfillment. And then way distal, all the way downstream, the most lagging of all, is the organizational impact of all of this. That's things like attrition risk or engagement. So ideally, we'd be measuring upstream so we can better manage all this stuff downstream. So again, why do we need a new metric? The thing is, up until now, there's been no psychometrically rigorous way to do this using a standardized tool that's designed for health workers. Okay? That's why we made WISH. That's why we made the Wellbeing Influencer Survey for Healthcare. This talk is too short to go through all of the psychometrics, all of the validation science, the full development story, but I want to give you a couple of key points. Number one, in terms of the validity, so that you can trust that this is a good tool. And then number two, and I think this is more important, what we're learning about this construct, our well-being, from the validation science, because we're learning some pretty cool things. Fundamentally, what is WISH? WISH is a tool that shifts the focus away from these individual states, are you burned out, and it shifts it to health workers' perceptions of those facets of our workplace that drive these outcomes. So WISH is asking health workers their perceptions across these 8 influencers of well-being: psychological safety, perceived social support, leadership support, work meaning, inclusion and belonging, justice or organizational fairness, work-life integration, and working conditions. Now, the process of developing and validating a metric is long, but broad brushstrokes here. The first phase, largely qualitative. You get an internal team of experts, primary team, who work with an external team that's, for us, with about a dozen people covering medical anthropology, the psychology of human happiness, psychometrics, survey design. And there's an iterative process where the teams go back and forth, from prototype to prototype, refining items until there's a measure where the whole team agrees this thing is measuring what we think it should. Okay? Qualitative content validation, that's a quick overview. The next chapter is largely quantitative. I want to go through a couple of elements of that. Psychometrically, you want to see, how does this tool work internally? How do these items relate to each other? And then how do they stack up against external measures? Can this thing predict behavior in humans? That's like the ultimate thing we're trying to get at. So psychometrically, we look at first the internal validity. We call this internal structure. You can use methods like factor analysis, item response theory, to get at some key questions. And those questions are, when health workers take WISH, are they conceptualizing the construct in the same way? Another way to say this is, are there latent domains at play here? So on the screen, you see 32 X's, okay? When health workers take WISH, they see in front of them 32 items. Now, as we look at the data of thousands and thousands of health workers now, we can see patterns emerge in the data in terms of how these items relate to each other. And this can give us quantitative evidence to support the hypothetical model that all these experts spend so much time on. And what we see is that we can find evidence that supports this model. We see in that big, bold purple column an overall unidimensionality, which is that there's a shared construct at play here. And that shared construct, to me, is culture of well-being. And then you see that the item variance partitions into these 8 sub-buckets. Those are the influencers of well-being. So without getting too complicated, what we've got here is advanced psychometric modeling telling us that our model and our construct, it's consistent with what the data is actually doing in real life. Pragmatically speaking, what this means is when we score and interpret wish, we should score at the overall level, and that's going to tell us something about the strength of well-being culture. And then we should score at the influencer level, which tells us about the patterning of well-being culture. Okay, the next step of quantitative assessment of metrics is where you look at the external validity. How does this tool stack up with established tools? You want a tool to be related to related metrics, but not so strongly as to indicate redundancy. You want to say, are we measuring something new? What you see here is a heat map of correlations between WISH here in the green box and all these gold standard tools, the Maslach burnout inventory, professional fulfillment index. And what you see are correlations that for behavioral constructs are very, very strong. Human behavior is messy. Well-being, fulfillment, burnout, these are broad constructs. These are very strong correlations, but they're not so strong as to indicate redundancy. This tells us we're picking up on something new. I want to highlight here the intention to leave row. You see here that WISH is strongly coupled with intention to leave. That's critical for anesthesia right now. Take that thought, keep it close, we're going to come back to it. Other things you can do. What you see here is each colored line is a different department of anesthesiology. And what we see across departments, we can demonstrate that higher WISH scores, as seen on the x-axis, correlate with a lower burnout burden for a department, and lower WISH scores correlate with a higher burnout burden for a department. So we can see that culture of well-being is a very important departmental level indicator. There's a lot more you can do, but these are just some of the things that you can do to demonstrate that this metric is measuring behavior in a way that matters. So to summarize in terms of the is this tool good question in the validation, scoring WISH, whole tool, influencer level, and the psychometrics support the model that we have hypothesized. In terms of external validity, we should be looking at this in terms of the scores are Goldilocks zone coupled with other tools, but we're getting at something new. And then this predicting outcomes thing is actually where I want to spend the next 5 minutes or so on. This is where we're moving beyond, is this tool good? And we're moving into what can the validation science teach us about health worker well-being? Okay, so put a stamp on it, valid. Now let's move beyond that and let's talk about what are we learning from WISH. A lot of you have probably seen this slide. Right now, anesthesiology, we have the highest intention to leave of any field in medicine. Big problem. We have a workforce crisis. This is not helping. Multiple large data sets have demonstrated this at this time. This is a huge question in front of the field right now, being what do we do about this? What should we do about this? How should we unpack this? If we return to our hypothetical model, upstream we've got the systemic well-being influencers, way downstream we have things like attrition risk. Theoretically, we're saying if we measure upstream, we can better manage all of this stuff downstream. Can we demonstrate that this model holds water? We can. So you can predict intention to leave from WISH. What you see here is a multi-center sample from our WISH data set, 7 different departments representing every U.S. census region. And what we see is across departments, you can robustly predict intention to leave from WISH. Pretty good evidence. That's a forest plot that has a very profoundly impressive meta-analytic profile for the prediction capacity. It's not just intention to leave, it's also engagement that you see this with. Okay, that's compelling. Can we go a step further? And we can. Can we demonstrate that WISH has value added over these other tools, like burnout or fulfillment? We can. You can do the same thing where you do partial regression coefficients, where you predict intention to leave from WISH after controlling for those other measures. So what you see here is the first 3 are different types of burnout. It's scored across 3 different pillars. And then the last one is fulfillment. What you see is no matter what you control for, WISH is still able to predict the intention to leave after you control for those constructs, after you control for burnout, after you control for fulfillment. And we do the same thing for engagement, very powerful predictive capacity. Okay, is the inverse true? Can we predict intention to leave from burnout, control for WISH, and see if there's benefit? We can, there's no benefit. There's very minimal to small benefit. What you see here is predicting intention to leave from these individual focus measures after you control for the system's lens. And you don't see that much benefit. This is telling us that the system matters. Very profound finding for the science of well-being improvement. Can we go a step further? We can. This is an oversimplification. These things all interact in complex ways. We could do what's called mediation analysis to test how these variables interact. Essentially what this is examining is whether the effect of one variable on another is transmitted through an intermediate variable, and also whether there's a direct effect. And what we see here is that the data is consistent with the model yet again. Systemic well-being influencers, as measured by WISH, sit upstream of burnout, which is in turn sitting upstream of these things that are of organizational impact, like attrition risk. And it's not just intention to leave, once again, it's also engagement. So all of the evidence is pointing to a couple of things in my mind. This is well beyond WISH. This is more about how we think about our well-being as health workers. And that is that culture of well-being is critical. This is incredibly important. And this data isn't just telling us that it's important. This data is telling us how we should be thinking about what culture of well-being even means. So the next question that comes to mind to me is, okay, intention to leave, it's a big problem. We should be thinking about this upstream. We should be thinking about the system. How is our system doing? WISH can generate a phenotype of well-being culture for the field. What you see here are the WISH influencers on the x-axis, scores on the y. Every colored line is a different department of anesthesiology. And what we can see here are there's some pressure points in common, and there's some areas where that are doing better off for pretty much all departments. This can inform national dialogue to me. If we're saying intention to leave is a big problem for the field, maybe as a field we should be talking about organizational justice or fairness a little bit more, shared decision making, the rigor of how decisions are communicated. Maybe that's what we should be talking about in terms of how we want to help make intention to leave better. Also, I see some strengths here. Psychological safety, procedural support. Doesn't surprise me that we do a little bit better there, relatively speaking. Psychological safety and things like that have been a hot topic in our field for some time now. So this is data that tells us we can lean into our strengths. And then the last thing that I think that is very useful is we can now benchmark culture of well-being across the field. We can find those departments where they're doing really, really well in something. We can go in there, we can study it, we can try and figure out what are they doing, figure out if we can find a rigorous way to scale that, and then have that modeled as a behavior across the field to try and make things better. So, take-homes, cultivating cultures of well-being. I think that's the most important thing we're learning from WISH at this point. And then as for WISH itself, it's offering a framework and a measurement tool. So for departments who use WISH, they can get local insights that can guide strategy. For the field, we've got a framework that can elucidate what matters and how we can be thinking about the conversation to make things better. And then for researchers, WISH is filling a key gap where it's allowing for more granular evaluation for intervention efforts. This was a long effort from many people. These are the core team members who started this journey years ago. Dr. Beth Duggan at University of Alabama, Max Mansoff, Max is right here, he's our psychometrician, medical social scientist. Jose Hernandez-Carcamo is program manager at UCLA for Wellbeing. Dr. Theo Winger, informaticist, pediatric anesthesiologist, dear friend Christine Park, until very recently at the University of Illinois Chicago. And then honestly, the number of people I want to thank are too long to name them all. These are all the people who are at a very high level using a lot of their time and energy to push this effort forward. My profound gratitude goes out to all of them. If you want to get involved, that QR code will bring you to our website. You can shoot us an email and get roped into the WISH efforts. And with that, I'm going to pass the baton.
Good morning. Oh, that's really loud. Okay. I'm just using this because you won't see me if I stand in front of the computer. And this is me wearing big girl shoes. And we're like, there we go. Okay. So let me clip this up somewhere. That's pretty amazing work that we're doing. It's a tough act. Can you hear me just as well? No, tough act to follow. Elliot. But anyway, I'll start here. So my name is Stephanie Black. I'm recent, after many, many years at the Children's Hospital of Philadelphia, being involved as a program director in education work. I recently transitioned over to Dartmouth Health, where I'm working on education for a different generation of folks and faculty affairs and stuff. And I wanted to talk with you about a collaborative effort between the ASA and the Society of Pediatric Anesthesia, a network of educators and a network of well-being content experts in the development of a novel web-based curriculum. I think the first one has to be on here, right? Is that true? Did it go? Okay. I do want to make a couple of disclosures. So I don't have any financial disclosures, but I will say all of the web-based curriculum that you're going to see here is actually housed on the site for the Society for Pediatric Anesthesia. So any affiliate links will go back to there, and I just wanted to thank them for their development of the web-based interface and their support in that regard. I don't have any financial disclosures, but I will say that I do have a lot of implicit biases about education and healthcare provider well-being that are deeply rooted in my own experiences. I do have a formal background in education, which a lot of physicians do not, even though they're put in the position of being educators. I am a recovering fellowship program director for a large pediatric anesthesia fellowship, so I carry that bag with me. I do love collaboration, and I love building things, and I'm deeply committed to professional sustainability and helping people do their best work. And I have been described as suffocatingly optimistic. That being said, I wanted you guys to know I'm going to out myself in psychological safety. I have an embedded link in here that I'm terrified is not going to work. So it's going to be amazing. We're all going on this journey together. Okay, so imagine, let's go back to 2019. We know that physician burnout is incredibly well described. We know its prevalence, especially in anesthesiology, and so we're already sitting with that. We also know that the ACGME has turned a lens to that because they're paying attention, and they know that this has a lot to do with provider engagement and sustainability in the field. And so suddenly they start putting out well-being surveys to trainees and to faculty, and then they say, we're just going to look at it, but we're not going to care about it, but we do really care about it, but we're not going to tell you when we're going to care about it officially. There's going this murky phase of that rollout. But they do have in their program requirements, both for fellowships and for core programs, that we have to cover the issues around substance use disorder, managing fatigue, burnout, depression, suicidality. There's a host of topics that need to be covered as dictated by this regulatory agency. We also know that most physicians have, and despite the docere being to teach, most of us have absolutely no formal training in educational methodology, even most program directors also don't have training in educational methodology. So fast forward one brief year, and wow. I wrote an editorial around this time saying the gift that COVID gave me, because again, suffocatingly optimistic. There's so many innovations and so much we learned about ourselves as a human entity in 2020. And we learned a handful of things. One, the need for well-being support. It was absolutely greater than ever, just blew up. We also know that educating on well-being topics for both trainees and staff elevated from just a regulatory requirement to a true moral imperative. It was a matter of life and death. We know that social distancing required a huge pivot in our approaches to education, and that virtual platforms became necessary for all commercial sectors, education sectors, you name it. We knew that anesthesiology educators were really busy being anesthesiologists during this time, and there was an isolation for a lot of medical educators who were responsible and accountable for providing content. They really felt like their hands tied and weren't prepared, nor did they have the time to deliver. So we realized we really had to build a bridge between the current state and the ideal or expected state. So call to action, anesthesiologists rising up and doing the things. we decided as a team of well-being experts and content experts, as well as education content experts, that we were just going to solve this problem together at a grassroots level. So a bunch of us started meeting sometime in, I don't know, maybe the summer of 2020, yeah. And we just decided we're just going to build something to solve this problem. So what we decided to build is an online curriculum that is universally applicable for all levels of medical professional, interdisciplinary, and such. And that we would figure out a way to build it in a way that people who are on the ground doing the work felt like they had the content and expertise to be able to deliver the content. So we decided that if you're going to build an online curriculum, it has to build community, which means it needed to be able to bring people together and reverse some of that social isolation that people were finding. It had to be practical, so which meant that we knew that some elements of it were going to be virtual or asynchronous, and we also wanted some live interactive element because that was going to be reversing that social isolation. And we wanted educators who were responsible for delivering the content to feel like they knew enough to be able to stand with authority with the information that they had. We also wanted to make sure that we're serving the individual programs and the institutions, because there were a lot of requirements from all over the board. So not only meeting requirements, but also meeting the actual need of staff. So we got together, we started with a needs assessment. We did a Delphi method among well-being education experts to arrive at what we thought were our 3 highest yield content areas from the topics that were proposed. If you remember the Delphi method, it's like where it's like a expert weighing in, refining down into like smaller buckets. So some of the stuff covered, or some of the stuff was proposed, everything from conflict management to mentorship, managing adverse events, mindfulness, and such. So from there, we went to the curriculum design model. So every good curriculum starts with a needs assessment. So that's where we did a deep dive into the literature as well to try to figure out what's already out there. And what we discovered is like not much. Yeah, so what needs to be done, we drilled down to understand some of the regulatory requirements from the ACGME and then looked at the well-being literature to figure out what the greatest social need was outside of that. So when I think about curriculum design, I think about iterative like PDSA cycles. There's a lot of things, a lot of stuff that shares in common. So you do a needs assessment, it's the planning part, and then you design the curriculum and you execute it, that's the do, and then you look back at it and figure out how to make it better. So that's why if you have to think about, I'm not a curriculum designer, like all of you guys know QI, it's just like QI for education. Okay, so this is a QR code, an indelible link to our PEDS anesthesia wellbeing curriculum. In case this embedded link turns out to be like an epic technology fail, which is a Luddite, I am almost confident, despite my suffocating optimism, that it might be. Please just go to this on your device. Yeah, okay. So, and then now if I botch this royally, you can continue on your own. Okay, so let's try that. So what I will say is the curriculum takes about investment of about an hour and a half for the participant. Each of the modules takes about an hour and a half. And for the facilitator, it takes about 2 hours. For the participants, it's about a half an hour, 45 minutes of pre-work in advance. And then for the a live facilitated hour-long session. And then for the facilitators, it usually takes about an hour of preparatory work to really get yourself familiar with the material, and then that overlap of that hour live session for facilitation. Okay, let's try it. Can we do it? Oh my God, it worked. Nailed it. Okay, so this is from the Society for Pediatric Anesthesia. This is what the wellbeing curriculum looks like. This is probably what you're looking at on your phone. Is it working there? Oh, it didn't. Oh no. How do we do that?
Oh, girl, I got no idea.
Oh, you guys.
Max knows.
Max, help me.
And just so everyone knows, you do not have to be a Society for Pediatric Anesthesia member.
Oh, heavens no. Open access.
For everybody.
Okay. Yeah. Okay, so here's the deal. We planned for this. Okay, so let me see if I can close that out. I'm going to go back to this. So, sorry, it worked on my presenter view. I got very excited about that, which is how it worked on the speaker ready room. Okay, so planning ahead. Anesthesiologists always have a contingency plan. So these are just screenshots. So what you'll see when you go to the wellbeing curriculum is like a page, a welcome page for, that has a little bit of information about like expandable things about the curriculum itself and how it was designed, and then how to use the wellbeing curriculum. And then under it's really, really granular instructions, and I encourage you to just scroll through it on your phone. The about stuff is kind of cursory, a lot of the stuff we already said, but the how to use is really like step-by-step instructions on how to make this work. So in each of the modules, there is a portal for facilitators and a portal for participants. It's all open access, so like if the participants want to look at the facilitator page, great. Like who cares? There's no like cheating here. But I will say these are, after that Delphi method, these were the 3 buckets of things that we decided were highest yield. So one of them was about adverse events and peer support, which I'm going to explore here. That ties a little bit back into what Dr. Margulis was talking about. We talked about personal resilience, and then burnout, depression, substance use disorder as a hat trick of badness. So, okay, so if you go to the facilitator, so going back, if you go to this facilitator portal under the hands there for adverse events and peer support, this is what will pop up onto the screen. And basically it gives you, again, step-by-step stuff that you can do. How to use the curriculum is a great way to start. Dr. Sam Yanofsky helped co-author a how-to guide that is so explicit and very clear about best facilitation practices and step-by-step instructions on how to work your way through the curriculum. Each of the under where it says adverse events and peer support, each of those lines is a hyperlink that will take you to an open page with documentation. And so for the facilitators, it's got the how-to guide, and each of the buckets has a how-to guide with facilitation practices, an annotated, very, very deeply annotated facilitator guide that has a lot of content so that you feel very confident when you have to facilitate the material. And then also a case stem, all of these are case-based, a case stem and questions that is what actually you use during the live facilitated session. So this is what's on the facilitator portal. If you go to the participant portal under the same bucket, you'll find several things. 1, step-by-step instructions for the participant. We couldn't have made it any clearer. And then 3, sometimes 4 hyperlinks that will open up a pop-up page for each one of the pre-work. So the way that the participant portal is supposed to work is that there's some pre-work you do in advance. Of the pre-work, there's about a 15 to 20 minute video that's narrated to content experts in the field, many of whom are sitting at this table and in this room, who give a talk about the content area. And then there's a self-reflective exercise to really like cognitively activate you with the material and engage you with the questions. So it's like some interactive exercise. And the participants are expected to do that before they show up for a live facilitated session. And then in this particular module, we also provided a tip sheet for best practices for peer support. And then in each of the participant portals, there's a resource list at the bottom, which is about 1 or 2 pages of annotated resources that people can look at if they want to get more information about that. Yeah, so I think that's all that I will say about that. So here's the next steps. Please toggle through the stuff on your phone, play with it a little bit. You can look at all the content. I will say for us, there's going to be we've gotten some pretty strong endorsement from the Society for Pediatric Anesthesia, obviously, the ASA, and also the Society for Education in Anesthesia. There's going to be links forthcoming to the embedded organizations there to these pages and this content. And it is open access. There's a few things, in society pages that are behind a firewall that you have to log in for, and this one is absolutely not one of them. It's readily available wherever. In each of these pages, you'll see down at the bottom, there's like a QR code, and that links to a REDCap database for us to be able to do the study act element of iterative refinement for the curriculum. So we'd encourage people when they facilitate it to go ahead and both participants and facilitators to give us some feedback on how it works for them or improvements that we could make. And then for the evolution, there's a clear process for developing new content. And in addition, when we started putting this together, we put together like how to build materials for the curriculum as a separate how-to guide. That's not forward-facing on the website because it's just not, but all over it says if you're interested in contributing more content, obviously there's a ton of content that needs to be contributed. We don't have anything on suicidality, for example. There's like a whole host of other topics that we'd love to see put together. If you email me, I am more than happy to provide you with a how-to guide about developing content and collaborators who are like-minded to help you develop additional content to be able to deliver. So we need you. Help build something fun with great people, and thanks for your patience with our technology foibles.